Good morning, everybody. It's kind of early here in Kentucky. Depending on where you're joining from, it may be even earlier. My name is Lee Taylor, and I'm going to go over a few housekeeping items before we get started. Our session today is in Zoom, so that means that all attendees are muted and your videos are off. We are recording the session and we'll make that recording available soon. You may have already seen it in chat, and if not, I'll post it again. We have a link where you can see the recordings. Please use the Q&A feature at the bottom of your screen for questions. We will have time at the end of the presentation for questions and answers. American Sign Language interpreters will be on screen throughout the session. You may change your view at the top portion of your screen. Also, we are using a live transcriptioner this morning. So if you do not see that on your screen and you would like to, click on the CC button at the bottom of your screen. We know that there may be technical difficulties today, so we appreciate your patience as we encounter any. Okay, certificate eligibility. This is for CEs and certificates of attendance. You must be in the content portion of the webinar for at least 90% of the session to be eligible for certificates. This is a mandate by the boards. Please do not leave the webinar until the conclusion of the Q&A, as that counts as part of the session. You do not have to enter your contact information in the chat, as attendees and your time is tracked by Zoom. You must use the same email address to participate in the session as the one you used to register. If you're joining by your phone, but you use the link that was sent to your, let's say, work email, completely fine. You're still going to show up. What you don't want to do is register from your work email and then the next time register from your home email. You have to use the same one for every session. That's the unique identifier used to track attendance throughout all of the learning series. In the coming weeks, you'll receive an email from me that will provide a link to access the session evaluation, then your certificate. You will land on this MTS tracking page, and you'll have an option to select the 2022 System of Care Learning Series. You must complete the session evaluation to proceed to the certificate. Lastly, you are responsible for printing your own certificate. We do not mail or email those. This website on the screen houses several years of the System of Care Academy, so if you lose your certificate, you can go back to this website and print another. Now let's learn about our presenter. Marcie Timmerman has served as the Executive Director of Mental Health America of Kentucky for 5 years. She is currently Vice Chair of the Kentucky Mental Health Coalition, Co-Chair of the 988 Advocacy Coalition, and serves on several other coalitions and boards. She holds a Master's of Health Administration degree from the UK College of Public Health and a Bachelor's in English from the Ohio State University. And now I'm going to stop sharing and turn it over to Marcie. Welcome, Marcie.
Thank you so much for having me. Everyone, oh goodness, of course the share screen wants to pick the wrong screen, so give me one moment. Always a technical snafu, right? All right. Well, welcome to Here's the Tea. Thank you all. I'm a tea drinker in case folks didn't realize, so that's why I was like, oh, this works. One comment, take care of yourself today. Some content here might get difficult to read, see, or watch. That's the case with all mental health content, right? So 988 is available 24/7, 365 days a year for any mental health or non-medical substance use emergency. So if you need other resources, just go ahead and click on our website. And let's see here. Who are we? I wanted to give you a brief overview of Mental Health America of Kentucky. We were established in 1951. We are a 501c3 charity. We are the advocates who really started the Department of Mental Health. We provide free education. We do a lot of advocacy. And we try to bring research from research world to real people, which is what we're hoping to do today. We have a before stage for philosophy. As you'll see here, that's our hashtag. You can find it all over the internet. We are looking at mental health from a public health view. So we want to get to people before they're in this stage 4, where symptoms are persistent, severe, jeopardize someone's life. So maybe we are preventing suicide, we are preventing jail time, we are preventing involuntary commitments. That's the goal. So our screenings that we're going to talk about today are actually our part of trying to stop this cycle of people going from jail to prison to the hospital and back to jail, back to prison, back to the hospital, and just repeat. We really want to stop that. And really the way to do that is to get people early and to get people understanding mental health symptoms, warning signs, and really start talking about their mental health. Now, the COVID pandemic was terrible for lots of things, but for mental health conversations, it was actually really good. We talked a lot about mental health and mental wellness and really introduced that as a very common topic to talk about. And I think that has helped a little bit with the addressing the basic literacy, but we still have a long way to go. You heard a little bit about me already, but 2 things I am not. I am not a mental health service provider, so I do not pretend to be a provider. And I am not a data specialist. So there may be errors. If there are, let me know. So I wanted to define quickly what health equity even is, because we're talking about health equity from our screenings lens. Health equity is achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. We'll get to more of that later. That's from the CDC. Behavioral health equity is the right to access high quality and affordable healthcare services and supports for all populations. That is not just including race, it also includes LGBTQ people, people with disabilities, those in rural areas. So it's a much bigger picture than we sometimes think of when we talk about equity. And to make sure we're clear on equality versus equity, those are 2 different things. And I stole this from Rashad Abdur-Rahman. He works for the Department of Behavioral Health, and he did a racial equity and behavioral health presentation with us a while ago. So I've linked that here for anyone who's getting the slides as well. But community resources are available equally in these 2 communities here on the left. See? On the right, every community has what they need. They have equality. So that's really the difference. You see, equity is kind of the same thing for everybody, and equality is what we need given to us. So there are social determinants of mental health, and a lot of folks don't realize that. We talk about social determinants of health, but mental health ones are very similar. And it's an interesting give and take, though, the way we describe this. So there are lots of things that feed into poor mental health and risk of mental illness, but actually the mental illness and mental health issues also feed back into those problems. For instance, someone who has severe psychosis may have a problem with food insecurity because they're not able to go to the store, or maybe they're not trusting their bank, so they no longer have access to their funds, their money. So that's just one example of how that illness might affect their ability to get food. But also, not being able to get food puts you in a high stress situation and may make you suicidal. So it's a back and forth conversation. So some of the social determinants of mental health: underemployment, so not having a job that pays enough to buy things or rent or other things like that. Food insecurity, we kind of sort of covered that. Housing instability, getting kicked out of your house because you happen to have a breakdown is a problem. Social exclusion, loneliness is a big issue. Poor neighborhoods. Just being in a poor neighborhood can be an indicator that your mental health is negative, not because poor neighborhoods are bad necessarily, but because of the other things associated with poverty, unfortunately. Education inequality. Again, sometimes that's a matter of where you live, right? But it can also be maybe you were anxious or depressed or had other issues. And poor access to healthcare, which is a big thing that we talk about with mental health. So there is a legacy of racism and discrimination in mental health care. It has contributed to fear and distrust in seeking care, including misdiagnoses and unequal access to mental health services and supports. Thus, a focus on equity must be core to mental health policy. That language I actually pulled from our national organization's interim public policy and equity framework. And I want to stress that it's really important to us that we start tearing down these structures that keep people out of mental health care. We want to bring them in when it's necessary and needed, of course. Oops, and I forgot a note here. On this aspect as well, one of the examples that we have of this is we have actually medically diagnosed people in the past with things that aren't medical issues. So from a behavioral health standpoint, we once had a diagnosis for slaves who were seeking their freedom in the United States. We would treat that as a mental illness here. That's pretty sad. We also used to use the word gender dysphoria for people who are transgender. That is not a mental illness. I just want to be clear about that. And so we have structurally hurt people, right? And those are just a couple of examples and things that we are trying to get rid of. So what are these screenings we're talking about today? Where did they come from? Well, we call them our checkup from the neck up. They are mobily accessible. They are on the internet. They work. They are actual clinical tools. So the things that you would take at the doctor's or therapist's office before you're seen, those are the tools that we used. We adapted them and put them into a depression test, an anxiety test. And on the next screen, we'll actually show you those. So this is all the screens we have available as of yesterday. This self-injury survey is our newest one, but we have a depression test. We have postpartum. We have a psychosis test, which we have been seeing an increased number of people in. We have a youth mental health test. We've even got an addiction test. Are you not sure if you're drinking too much, if you're taking too many drugs too often? This addiction test will be helpful. The ADHD test is another newer one. You will not see those results or the self-injury results today. Those are both newer to us. And we do have two of them offered on the front screen in Spanish, one for depression and one for anxiety. Those are our most commonly taken screenings. And yes, I am a little slow sometimes, but oh my goodness, there were 54,731 screenings in Kentucky from January 1st, 2020 to June 30th of 2022. 54,000, y'all. That's a lot. Just for additional context, from March 18th to December 31st of 2019, we only had 23,000 screenings total over several years there. So we had a lot of screenings coming in because of COVID pandemic, people at home looking for mental health help, which is fantastic. This is what we want. We want to be there for people. Thanks for all those claps I keep seeing come up. I love the emojis. So our most frequently taken screenings are for depression, anxiety, and bipolar disorder. You'll have to forgive my use of GIFs, folks. I love animated things because I sometimes get boring with this data. So the severity of our screening results, I think, is a very important factor we want to look at. 78.64% of those total screeners had moderate to severe symptoms by the screening status report. So these people are already having problems that literally may be critical and definitely seem clinical from our screenings. They need help of some kind, right? So only about 21% are negative or minimal to mild, which doesn't mean that they don't need help, but means they're not indicating that they're in extreme circumstances, which I think is a good thing. I've got a question here. How do you know if people completing the assessments are from Kentucky? How do you know if the same person did not complete the screener? I actually get to that in just a minute, but I will go ahead and tell you from Kentucky, people are asked questions that are demographic questions. They don't have to answer them in order to use the screening. They come after the screening. So they can choose whether or not they're from Kentucky in a drop-down box. And some of them also give us their zip code. The zip code data I just received, so I don't have that broken into today. But this is all anonymous. I should mention that too. They're free and they're anonymous. So when you go to our screening and take it, it is completely free. But we do not know that the same person doesn't complete the same screener over and over again. We do have a way of knowing whether or not they're doing it in the same 5 minutes, 10 minutes, short term. But if they're taking it to monitor their symptoms, we don't know that. So my apologies if I answered that incorrectly or said anything incorrectly earlier. But I do think it's important to note that even if it's the same people taking it several times, that they're still showing moderate to severe symptoms, and that's concerning. One example of data that I get from our depression screening result is just to show you again, just to illustrate a little stronger that we've got moderate, mild, and then we have a ton of severe depression coming through. And when someone indicates that they are suicidal, the 988 number pops up in front of them and they're not allowed to proceed without acknowledging that they need help from an emergency service. So they can choose to ignore it. We don't have the ability to force them to do anything, obviously, but we strongly remind them several times that they need to call 988. And for those who aren't familiar, 988 is the new way to call the suicide prevention lifeline. So that is the national number in the national system. But luckily here in Kentucky, we actually answer it most of the time here in Kentucky. So most of our local centers are answering 988. And I'm happy to talk more about that later. So one thing to hold your horses on, and this is my disclaimer about this data, all screenings are conducted by people who come to the website to do that. There is no control group. This is not every Kentuckian data. One screening does not equal one person. I mentioned that already, right, in that answer. Individuals can take screenings multiple times in a day, month, year, etc. Online screening is not available where you don't have internet, where there are slow data speeds and things don't load properly, and where the site is blocked, which we found several of our jails and prisons have us blocked because they block everything pretty much. And limited number of screenings in Spanish, and it's not available in other languages at this time. So that's important stuff. So let's actually look at some of the data. Household income breakdown. The total number of responses to this question was 46,730, which is 85.38% of the screenings total. So that's actually a pretty good number of folks. Oops, my apologies. I was trying to move my screen and I can't. All right, so household income. So y'all might notice how that very, very tall bar, that is our less than $20,000 a year reported income. The next one is 20,000 to 39,999. So almost 40K. And then the third largest bar is the 40 to 60K income. So the majority of our respondents make less than $40,000 a year by pretty visually a long shot. The median household income in Kentucky is $52,238. So let's go back one second. 52,000. That's where most of our screenings fall. About a quarter of them total. So that's not too bad. Median means the equal number of people roughly falls below and above that income line. That is the census number for 2020. So just to kind of be clear that about half of Kentuckians fall less and about half go more than 52,000. The USA poverty line is $13,590 for an individual. So that's most of those people in that first bar are in the poverty line. And that's for an individual. So if they have a family, it's definitely much higher. The age of our screeners does tend younger than 25, which will impact the income data to a definite degree. The number of students and younger individuals doesn't account for the large number of people who responded, which is really interesting. So way more than just students answered. What we don't know about this aspect of it is whether folks are rural or urban or other things like that. So those are some qualifications on that. Conclusions we can make though. Online screenings being free of charge makes them more accessible to lower income individuals. That seems to be pretty clear to me. Accessible to screening does not mean accessible to treatment. About half of respondents are or have been in mental health treatment. Medicaid expansion has helped a lot with that, and we need to continue to expand access to treatment, including adding more providers. Wider outreach to Kentuckians means we're likely continue to see growth in screenings under the 60K household income. We expect to see a lot of growth in that area. But lower income doesn't necessarily equate with lower mental health literacy. It's something we're thinking may be justified by these numbers because a lot of these folks are coming to us. They're willing to talk about it. That's pretty good. It's not necessarily a literacy standard yet, but we're getting there. Any questions on this part of the data? What do I attribute to the big increase in screenings this year? Christy wants to know. It's pretty much COVID-19. There's no other way we can say it. It was the pandemic for sure. Our national screenings went up 3 or 4 times as many screenings in 2020. So the fact that this data is from January of 2020 through current day, but the trend keeps staying high for us here in Kentucky. I should mention that. I didn't do trend, and I should have. We have roughly 7,000 screenings per quarter coming in now, every quarter, since the beginning of the pandemic, but through now. So yeah, we're hoping that maybe this just means people will get used to screening, which is fantastic. And that maybe even providers will use us. One thing I didn't mention with the screenings is people do have the ability to either print their results or to email them to themselves or whoever they choose to email. We do not track any email or personal data that they don't allow us to do. So the demographic data is all voluntary, and we do not keep their email, and we never ask for their name or their social or any other way to indicate who they are. We do keep bots out by keeping people away who have the same IP address over and over again. So that's the only thing we do. So on to kind of the racial breakdown. I think this is really interesting. Our total number of respondents to the racial question, only 15,197 since 2020. Whoops. That's 27.8% of our total screenings done. Now, as y'all can figure out probably and guess, I'm sure it's hard to read, but that very, very large bar is the white non-Hispanic folks. We're shocked, right? Kentucky is predominantly white, so that bar will always be our largest probably. But these other bars, we have a little breakdown on a different screen to help see. So this is our breakdown on the left of what we have in our screenings data. And on the right is racial equity makeup data for Kentucky for our 2020 due to the census. So we're pretty close on the white folks. We got a little ways to go with the Black, I would say, but we are improving. Our Black access number has continually gone up, which is wonderful because I think folks are starting to trust us more with knowing their race a little, because that has improved since 2020. American Indian, Alaskan Native, we actually asked that in several places. So we had to do a little math here, which is hopefully fine. Just to show 0.87 to 0.3, we're actually reaching more of them here in Kentucky than we have as a population. And then 1.68% Asian with an asterisk because we have Middle Eastern broken out down here. Middle Eastern is not a census category. It's something we just started tracking in 2022 because our Middle Eastern friends and neighbors and people who give us input at the national level asked to be separated from the Asian category. There are very different needs for different Asian cultures, including the Middle Eastern one. So they wanted to better track what those needs might be through our screenings data. So we separated that out this year. Native Hawaiian or Pacific Islander, there's a couple of different categories that have changed names over the 3 years of this data. So we compiled them all together. That's why there's an asterisk there. But we're actually reaching pretty decent numbers of people compared to our population now, which I think is encouraging. So some things we can conclude from that. Kentuckians responding to these screenings are more comfortable sharing their household income than they are racial ethnicity data by a long shot. I think that's pretty clear. We're doing a better job of reaching the non-white and Hispanic populations than we would have assumed by population data. And as far as those who are willing to tell us about themselves. So that's a qualifier on that one. We do need to clarify how and when we use this demographic data so that individuals can feel more comfortable providing it to us. I think that's important. It's likely we need to improve our outreach in Black communities in Kentucky. It's also possible that they're just not clicking their race, and that's fine too. And based on this data, we can hypothesize that more non-white Kentuckians are reaching out to us through the digital platform, perhaps because of comfort with the computerized nature and the anonymity that is assured. Things we don't want to say from this is that non-white Kentuckians need more mental health assistance than white Kentuckians. That's not true. The low percentage of respondents to the demographic data definitely helps us not support that claim. Given internet access and other technology and knowledge concerns across Kentucky, that actually would be really probably prove false. We're doing a great job reaching non-white Kentuckians. I can say that, but really that low percentage of respondents kind of invalidates that. We need to do better at explaining where that data goes. I was asked, do we provide information about services after completion of the screening? Yes, we do. There's actually what we call our systems of support. It gets activated when someone finishes their screening. They can go on to our DIY tools feature, which tells them things like stinking thinking, how to think about positive thinking, offers worksheets and workshops that we've done to help with something they may have answered in their screening. Also, it does provide provider information if folks have filled out the information. And if you want more on that as a provider, let me know. But right now, as a navigator for the state of Kentucky, I generally am the one that pops up my information does. Just because Kentucky is pretty small compared to our national partners. Alrighty. So breakdown of the LGBT data. We have 13,714 respondents who self-identified as being LGBTQ as at least one part of their identity. Approximately 144,000 Kentuckians identify as LGBTQ. They are 3.4% of the total population. We're reaching 9.5% of the estimated LGBTQ plus Kentuckians. So that's pretty good for us. That's a lot of growth for us. Definitely we had about 1% when I started, so we're doing better. And let's see here. And also, as far as the transgender folks, you can see the gender breakdown here. Females predominantly take mental health screenings. That is true across most healthcare, but especially true in mental health. The other category we break down, we ask folks if they hit other, if they identify as transgender. Other may also be non-binary. Folks are not sure what that might be. But in the transgender, we're reaching about 5.02% of that other factor says that they are transgender. So we're reaching some folks who are in that area. And honestly, that's been another area of significant growth since the pandemic. Folks are learning who we are, that we exist, and that these screenings are out there. So I think that's helping a lot. I wanted to make a quick note on youth suicide in the LGBTQ population. They're more than 4 times as likely to attempt suicide than their peers. Since the majority of our LGBTQ folks are students or identify as being under age 45, that's really important. The Trevor Project estimates that more than 1.8 million LGBTQ youth are seriously consider suicide each year, and at least one attempts suicide every 45 seconds. That's a lot, y'all. And it's not because they're LGBTQ that is the problem. That's not the issue. The place that they live, the systemic issues that they face as being LGBTQ are the reasons for these increases. Just to be clear, again, LGBTQ status is not a mental illness. So just something to think about as we look at our screenings, and I'll go back a step there. I just want us to think about the fact that of those 5%, right, they're probably going to be more severe, and they probably have other factors that would make them at risk for mental health issues as well. So we're glad we're reaching them. And then our age breakdown. I just wanted to share that with you all because I thought it's really interesting. The biggest piece is our 18 to 24-year-olds. But you'll see the second biggest piece is 11 to 17. If you combine those, you get more than half of our respondents being under age 24. And the 4 to 8 respondents, the ones who are ages 4 to 8, that is usually through our parent screening. And our same with the 8 to 10 is through our parent screening, parents taking a screening that are concerned about their children. Those numbers have been rising and concern me a lot. Also, there's been a lot of growth in our 11 to 13-year-olds needing help specifically. And one of our screenings is the only one that breaks it down to 11 to 13. The others are all 11 to 17. Our kids are struggling, y'all. I don't think that's news to anyone in the provider space though, because I was approached at the Primary Care Association conference by about 17 different primary care providers wanting help finding a child psychiatrist, child therapist. So they are needing folks really badly. And I think structurally, our screenings indicate that we really need to build more community among these youth to help support each other as well, to build some community space of mental health. Notes on the age data. It is an online screening. It's probably always going to skew younger. Digital natives are going to be more likely to access it, right? Also, that younger group of people, the majority of mental health issues happen before age 25. So we know that that's going to be a significant number of folks wondering, hey, am I okay? Or is this a serious thing? Access to the internet via any means remains an equity issue in Kentucky. We can't talk about that data without recognizing that. Inadequate access limits not only screening's ability, but also telehealth and other forms of treatment. And a factor I wanted to pull out as well, loneliness is the #1 reason Kentuckians report coming to our screenings since we started asking them in June of the first year of the pandemic, so 2020. Isolation was an issue during the height of COVID-19, but it continues to be an issue in rural areas, especially after our tornadoes and flooding, and especially for our Black, Indigenous, people of color, and LGBTQ individuals, they can feel isolated in a room full of people who don't look, think, or experience life like they do. We've got to do better at addressing loneliness. And there are lots of solutions for that I'd love to talk about with the rest of you. So maybe we can get a little interactive with that here shortly. Some factors to remember about behavioral health equity as a whole. We must continue to tear down barriers such as access to telehealth, access to providers who look, celebrate, etc. like us. So Black providers, Spanish-speaking providers, Middle Eastern providers, right? We need more of those folks in our space. We need better transportation access to and from treatment options. We still need to work on stigma. As much as I would like to say stigma is gone and we don't have any problems with mental health anymore, that's not the case, right? Stigma is still very strong on the ground in Kentucky. We are starting to chip away at it. It's starting to get better. There are non-medical model supports available across ethnic, racial, and cultural communities. Not wanting formal medical help doesn't mean you need to suffer alone or forever. Now, what do I mean by that? Well, I mean that in some cultures and spaces, there is essentially therapy with elders, with people you trust. And those folks, if we educate them on how to better help support their community, we don't necessarily need a therapist. I'm not saying that we never do. I am saying that if a cultural choice is to go to someone who would be seen as an elder, then we need to work with what we have and work with that space, right? It doesn't have to be a medical model prescription treatment option. Distrust in the system has been well earned historically. For instance, that case, right, where we said a slave who was trying to run away and seek freedom was actually someone who was mentally ill. That's not the case, duh, right? We know that now, but the system has said that before. So we have to recognize that these issues happen and that people aren't going to trust us just because we say we should be trusted. I think listening to people with lived experience, including them at the table, the way we did with 988, the way we continue to do with 988 is going to be really important. Taking steps to support their efforts from their community efforts and maybe even their individual efforts is really important going forward. And I can't be an advocate without saying underfunding of the mental health system has been chronic. For example, 1999 is the last time Medicaid rates were raised for behavioral health services. I don't know any business that is running on fee schedule for 1999. That is when I graduated high school. I am 41 years old, just for context. So be a mental health voter, people. People you choose to go to Frankfurt, ask them, are they going to support better mental health funding? Ask them, do they support raising Medicaid rates so that we can get reimbursed for what we're worth? Those are really important things. I do have my contact information. I had thought this was an hour, so I have lots of time for Q&A and we can expand better. And I do have the screenings up if we want to look at those. So let's go ahead and see any questions.
I know we had a lot of comments in the chat box. Someone commented that mental health issues can be so isolating before you add on pandemic and the age of the person.
Yeah, it's very true.
And someone else commented that they love what MHA does and the great resources available on their website, and your webinars are great too.
Well, thank you all.
As you were talking, I did drop in the chat box the link to your agency, as well as the screening tools and that DIY tool sheet that you were talking about.
Mm-hmm. Great.
And we have a question in Q&A. Could you request contact info so that you can make contact or connect screeners to services?
We feel that we don't want to do that actually, because the anonymity is what brings people to us, being anonymous. We ask them if they want to be connected to the MHA affiliate in their area. If they say yes, they get our information, and they get the information at the end for me instead of a list of providers here in Kentucky right now, because that system is so clunky. I'm not making Kentucky providers do it. It's better if someone calls me here in Kentucky and says, I have this insurance and I'm in this area and I can help them find somebody from there. And I walk them through the process so that they also have some self-advocacy moving forward. So that's how we've done it in Kentucky. But yeah, we really don't want to have any of their personal data in the system at all. Having it anonymous is really important to us.
So tell me a little bit more about your providers that you have in your system, because I know that can be a challenge.
Yeah.
We face that challenge with the state too.
Yep.
So how do you know what all providers are out there?
I don't think anyone knows how all the providers are out there, but when someone calls our office or reaches out, I really sit down with them and just teach them how to use, sorry about that alarm, teach them how to use their insurance features and functions. So whether their insurance plan has a list that's online we can access together, or if it's the community mental health center, which tends to be a default when folks have no insurance, obviously, but also I tend to default there for a lot of counties. They're the best provider and the largest provider and the most likely to have a first appointment. And if that's the case, then we go there first. And if they have a bad experience with a community health center, we either address that with their ombudsman and try to work with inside the system, or I help them find someone in the next county over. So that's kind of our process here at MHA. It's a little different, and I realize it's subject to change, but yeah, we don't really keep a solid list of providers. I try to keep my pulse on who might have some openings in Louisville and Lexington, but that's informal and really not fair. So I don't share it outside, and I really just start with their insurance and kind of help them from there. Because hooking them up with someone that can't take their insurance doesn't do any good.
Right. Someone said, I may have missed this, but do you have data on co-occurring disorders? Example, substance use disorder plus bipolar.
We don't collect that through the screening per se. It's kind of in there. Let me show you what it looks like from what I get from them so far. I have some raw data I haven't been able to go through yet, just for 2022. I got it last week, so forgive me on that. I was hoping to have it much sooner. Let me see here. Special populations does not cover that. We don't really have a way for more than one to show up. That is a flaw in the data I should make sure I mention next time. Thank you for that. And our addiction screenings, let me see how much of those there is. There's been an increase in them. 82% of folks who come are likely to have an issue, but it's really only about 800 takers. So it's not that much compared to that 54,000 number. So it's not a significant amount of the population yet in our screenings data.
That's very interesting. I would have expected that to be higher.
I would have too. I think that's a real place of growth for us, is to reach out to more of our addiction spaces and make sure folks can know it's out there as a tool.
Okay, next question. What are some outreach efforts or ways individuals are made aware of your site to complete the screenings? Is it mostly word of mouth in our communities?
It is significantly internet-based from what I can tell. So the linkage that I've seen at the national level, I haven't seen Kentucky specific data on how people come to the screening. I should put that as a qualifier. But generally, it's people searching for information like, I feel like crap, or I am very sad, or those kinds of things. And if they happen to be in Kentucky and answer the screening, I could get them. We don't have as many from our website yet. That has gone up a little bit since we've been better at putting it on social media that way, instead of directing people to the national link. Also, we did get some paid advertising during Mental Health Month, which was fantastic and appreciated. So in May of this year, we actually saw a good spike in May and June of screenings. Mental Health Month is a nationwide event that we've had since the 1960s. So it does get some traction and some press toward all the screenings across the nation. that helps a lot as well. So we're on NBC, CBS, in the morning shows, in the evening shows, the late night shows. So we tend to have a lot of appearances, which helps a lot as well.
Okay, and one person asked if you could talk more broadly about Mental Health America and their work and what you all offer in addition to the screenings.
Yeah, at the national level, that Before Stage 4 guides a lot of our goals. Here in Kentucky, we've been around since 1951. We want to make the system better. So that's where you all help me stay on a lot of these meetings that nobody else wants to be in at the state level. So we monitor Medicaid, we monitor the Department of Behavioral Health in good ways, right? Hopefully we offer really good feedback and constructive information when it's necessary, and we give the hurrahs when they're ready for them. So we really work with individuals and providers as well. I do a lot of training. So I do a lot of webinars, some of them private for corporations. I've done some for workplaces. We do a lot of self-care right now, a lot of debunking myths around self-care. So it's more than a bubble bath, y'all. More than that. That can be a helpful thing, but it's got to be a lot more, right? It has to be a change in how we think. We do workplace mental health work. So here in Kentucky, we actually have the Bell Seal, which is a fantastic way of finding out if your workplace is mental health friendly. And ways to improve it. From our national office, you get the experts there. I can help you get there. And also some of the extra training you might need and stuff I can offer on the ground here in Kentucky. So you wouldn't have to have our national folks do it. You can have me. So we also offer free education for folks, mental health first aid classes, for instance. I offer question, persuade, refer. But I'm really happy to talk on any topic with, obviously good citation and stuff like that for where I'm pulling my information.
Okay, and our next question, if you've addressed this already, I apologize for missing it, but I'm asking anyway. In your mental health screenings, do you screen for substance use disorder in clients, specifically all clients? And the same question for eating disorder. And when you popped up your raw data, I saw some info about eating disorders.
Yeah, I'll go to that in a second. Let me show them what the screening looks like on the website, though, so that they can see it. So we don't screen everyone for everything. Folks are given that opportunity to see that. So here's a bigger version of it. So they get to choose which screening they want to go to. So no, we don't screen everyone for SUD. That number would be much higher than 800 total. But we do encourage them to take related screenings if they indicate somewhere in their screenings, answer questions. So if they answer a question, say in depression, that we might think leads them to anxiety, it'll pop up at the end of their screening that they might want to take the anxiety screening as well. I hope that answers that one. And then eating disorder data. Yes, I should have shared that. Let's see here. Yeah, we have an eating disorder screening. And yeah, it's 3,532. So 3,532 were at risk. And 6 were avoidant restrictive food intake disorder. So that's very low number, which is good. And 41 of them were low risk. So that's really shows us that the people who probably have an eating disorder are wondering if they have one right now. And that's how they find us usually for that screening, is looking for things about their eating disorder, common phrases that we know from Google and other search bars that they would use. We always link those to our screenings.
And for those that don't know, we now have a Kentucky Eating Disorder Council that was established by statute within the last couple of years. And if you are interested in learning more about that, or how to connect, or if you want some data, please email. Her name is Kate Overberg Wagner, and we will drop her email address in chat in just a moment.
That's awesome. Yeah, we need to chat. I keep forgetting to do that.
I know that she's
helpful.
Yeah. I know that she's here. So Kate, if you want to pop your email in chat, that would be great. Someone asked, before I go back to the Q&A, someone asked in chat, I don't want to lose it, how do you share access to screenings?
Do they mean the data, I wonder?
I'm not sure. Can you clarify if you're talking about the data or just that website where all of the screenings are?
That
Okay.
is Walter. I have a feeling, okay, knowing who that come from. Walter, we share the screenings data through our social media. We put out an ad campaign. We put it through when folks are searching. We pay to have ours be toward the top of responses in order to help people get to valid information. We are concerned about that nationally. People getting to screeners and things that are pop psych and not really reality.
Someone commented and said the actual screenings.
Yeah, that's how we get the actual screenings out there. Mm-hmm.
Okay, what are some concrete actions that providers can take to make their services more appealing and equitable to broader populations?
Oh, there's a whole webinar on that. Or two. I think we've done at the national level too. Couple of quick things that come to mind. Doing some training with your staff, helping them understand, that racism is real and how they might have unconscious bias about all kinds of things, not just racism, right? Even somebody's last name in a small town, you can have unconscious bias against. So you have to think about that and really train that welcoming piece of things. I think to show that you really are an open and welcoming LGBTQ friendly practice, you really need to put, the Human Rights Commission sticker or a rainbow sticker, or be really clear about it, not just on your website in words, but in the space itself. Having it on the front door or a window, the reception window, something like that is really helpful. And offering options other than male, female for gender, offering things with marriage and things like that, offering a little bit more flexibility in that space as well. I think for folks of color, having someone who is trained in racial trauma training is helpful. Dr. Stephen Ifley is doing that right now. And it looks much better than it did a year and a half ago because we were able to help with that. So I think, and honestly, hiring people from those communities you're trying to reach, hiring providers who understand that community as best they can. We also offer scholarships. They're not much, they're $1,000, but we're really hoping to help, offer scholarships to more people in those spaces that we know that they're needed. We need more Black psychiatrists and therapists, period. We need more men, period, in a lot of places. And we need more child psych providers, obviously, so of all kinds. So those are some things we know we need. We need to do the things we need to do to actually train them and get them set up in the right community.
We've heard that across the state too.
Yeah. This is an echo chamber of sorts in that case. So,
Yeah.
But yeah.
Have you shared these data with providers yet? I'm curious as to how they see it aligning or not with their agency service recipients.
We have not shared it. I do a data webinar a couple times a year just to give it to anyone who wants it as far as state data. We have not given raw data to anyone in the state. I did include on my contact, and I'll pull that out here in a moment and put that in the chat as well. I went ahead and created a Google form, assuming that some of you on this webinar today might want access to the raw data so that I can send the Google form. It has to go through our national office since they own that program. They're also working on research with it. There is a way to look at it from a county level, even in our website. So let me get that link as well. Sorry, I'm forgetting where it's at. But our screenings data, we did start sharing with the world just this past year. But a lot of Kentucky data is suppressed because we suppress anything less than 5 respondents in any area. So that say that Black teen who's LGBTQ in a very tiny county, we can't find that person in our national data sharing. So, but I will get you that information. I'm sorry, folks, that I didn't have that at the ready.
Don't be sorry, you're fine. Even if this was a live training, we know that you would have to go over and pull up information.
Yeah. Like, oh, you never know what you're going to get asked, right?
It's one of the benefits of virtual trainings, though, is because when somebody asks a question like that, you can pull it up and screen share and see it in the moment.
Yeah. Let's see if that works. It wasn't coming up. All right. They must have taken it down for a few minutes. It might be having some technology issues because it is not working where it was. But if you go to mhanational.org, and I'll put that in there. can find the screenings data tracker. I have a feeling it had a glitch or two. It's been having some glitches. So.
And then our next question is, are organizations, schools, etc., able to access the screening data to help inform their local decision making?
The data available nationally is at the county level. So to some extent, yes. And if folks wanted zip code data, you can reach out to me and we can see. I'll put my email in the chat. I'm happy to help folks think that through and look at it with those eyeballs. I'm just getting zip code data now, so I don't have it for 2020 to present yet. It's taking our data team a little while. They've been a little busy on some other projects, so I can't blame them.
This is great that it's open to access. I know our regional interagency councils in Kentucky are frequently looking for data that is specific to their region, so this is a great resource.
Yeah.
Next question was, is MHA represented or able to be represented on any state, regional, local level planning team to help integrate all of the work happening statewide to expand mental health supports?
Big question. We are at the table for behavioral health TAC. So that is the Medicaid TAC. I'm not formally a member of the TAC, but I attend every meeting. So I'm kind of annoying there. I also am part of the 988 planning committee. So yes, there. I am not on a lot of these other meetings. So if there are places you think we should be, I'm happy to do my best to be a part of things. I know Clark County Mental Health Task Force has had me on a few times. Some of our substance use groups have had me come in and talk, but I'm always happy to partner with folks. Diane is asking TAC. Yeah, Technical Assistance Committees. Medicaid has assistance committees for various different special needs groups, including behavioral health. There's one for children. There's one for consumers to come and give feedback to the Medicaid program. So that is a structure that we have that has been in place for over a decade. So happy to be there, and it's a place to cause good trouble. So, and for hopefully troubleshoot things that Medicaid is doing, and then give them feedback if we're having problems. An example of that TAC really good, probably working exactly the way it should, was January when we switched to the single formulary of prescription drugs. We were able to give them feedback immediately that there were problems with that switchover and that people were having problems getting their medication, which is never good in behavioral health. So we were able to address it with the MCOs in the room. They're always at this, they have to be at the TAC. So that's kind of useful as well. They have to be there and find out information. And if they don't have it on site, which is fine because we ask really random things sometimes, they bring it back to the next meeting. So it opens up that conversation between advocates, consumers, providers, and all the other players in Medicaid. I hope that's helpful.
And another question in the chat is, can you repeat where to find the data? I think you said Excel format. Is that the link to the
That is the link
tracker?
that is down right now at National. So that is mhanational.org. And I will put it right there again. And if you look for screenings data, you will get it. It's just down right now. So, but if you just search for screenings data, you'll find it.
What is the most common mental health diagnosis that you're seeing due to the pandemic in teens, preteens?
We're seeing depression and anxiety being the number 1 and 2 screeners that are severe in that group. So I would say depression and anxiety screenings, not necessarily their final diagnosis, right? Because these are not diagnostic, these are screenings. So first step of the process, but we are seeing both of those.
And someone asked if there is data specific to children in out-of-home care.
There is not a question about whether they're in or out of home care. I will take that one to National though and see if we should add it.
And someone asked, are there other Mental Health America chapters in Kentucky? Where are they located? How can local providers connect with Mental Health America? And what about community members?
There is a chapter in Northern Kentucky. They're called MHA Northern Kentucky, Southwest Ohio. There are chapters across the country. We're in most states, but not all of them yet. And you can always reach out to us at that MHA national site. It has a list of all affiliates. And to reach us, I will put our website in here as well as my phone number and information. And we're on social media everywhere, and we do respond. So if folks are needing help that way as well. We're on TikTok, we're on Facebook, we're on Instagram, we're on YouTube, we're everywhere. We're on Twitter, all over the place.
If that information is on your final screen, let's pop it up at the end so that people can see how to connect on social media. I think that's a great idea. Another question, well, another comment. Kentucky State Interagency Council for Services and Supports to Children and Transition Age Youth has a racial equity standing committee that might be interested in these data and guidance as to how to take steps to improve equity within the system of care.
Great.
Are you familiar with that standing committee?
I am not, so it's always good to learn about new committees.
I can connect you with that after I'm the program administrator for the State Interagency Council.
Oh, great.
So I'm going to also put my email in the chat box if anyone else is interested in learning more about that standing committee, or the council. You can just email me and let me know. I was looking to see if I missed a question. We have a lot of information, links, etc. that's in the chat box.
Mm-hmm.
We can also send out more information later if you need. Just reach out to Marcie or me and we can send some of this information out by email. Another comment or question: not having access to medications in a timely manner is a huge issue. I had a pharmacist refuse to order a medication because I had not met my deductible, and he wanted to make sure I knew and would pay. I was never contacted about this. This caused me to have withdrawal because I didn't get it for about 4 days. I would love to see education for pharmacists about this. Even though they should know, they are sometimes not concerned. Are you guys connected with pharmacists in Kentucky?
We have not been formally connected with them other than to advocate together for broader access to medication. So we do partner with them on that because there's some laws that really prevent or could prevent because they're written badly. We've stopped a lot of laws from limiting access to medication. Unfortunately, we have heard quite a few stories of folks being denied a refill of a medication that you can't suddenly stop, or having an issue like that. So when we get those, if you want an advocate to help you walk through the process of informing them, educating them individually, I'm happy to do that. Or if folks have a connection and think I should reach out to do some education, I'm happy to do that. So it's part of our advocacy, part of our name.
Yeah. I do know later in our learning series, we're going to have somebody, Jody Jaggers, who's a pharmacist, come and talk about opioid efforts in our state and new services that are available. So check back with us. I believe that his presentation is in March.
Awesome.
I've also dropped in the chat the remaining of the October calendar and November's. If you want to register for any of those. You can also watch the recordings from the previous sessions. 2 are posted. I have 2 more to post. And you'll see that a lot of this information ties together. We had a presentation the other day about the Kentucky Incentives Program, the KIP survey, that talks about one piece of that is mental health screenings that were done. It's a screening that's used in the schools, but some of the things that they screen for are mental health, like substance use and any kind of mental health diagnosis, depression, that kind of thing. So this ties together with what Marcie's talking about, so be sure to go back and check that out.
Yeah, definitely. We're not the only screening source by any means. I'm just glad they're happening.
Well, and that one is specific to
right,
to kids too, like high school, and not all school districts participate in those screenings. So we know that we do have some gaps in our data, but we are working every day to try to improve that. Someone commented, we have seen change in insurances. We have seen a change in insurances changing mental health office visits from just copays to deductible and coinsurance. This will greatly affect access to mental health for many people.
Patricia, if you want to reach me later, we can talk about that. That would be something to find out who's doing that and how frequently it's happening across Kentucky.
Yeah.
And just how important that is, because copay and co-insurance tend to be the same. I want to make sure that I'm understanding the difference there. But that's interesting.
Okay, does anyone have any other questions for Marcie?
Sorry, it was a little short, y'all, but I hope it was good data.
It was a great presentation, lots of good information. And someone else commented and said we often have to advocate for our meds.
Yes.
True story.
True story. Shouldn't be the case, but it is often true.
And if anybody wants to check out the Department for Behavioral Health, Developmental and Intellectual Disabilities website, there is a provider directory listed there, and I'm going to put that link in the chat box.
Oh, another way to find providers, I forgot to mention that. Sometimes when I'm looking for a very specific need, I will use the Psychology Today's search tool. If folks aren't familiar with that, that is a place where providers can put a bunch of information, including what insurance they take, their specialties, their areas of interest. And that's a great place also to talk about that cultural openness, and bringing in, making sure that your picture is on there, and it's clear about what you're offering and the environment you want to set. It's a really good place.
And Marcie, will you pop that last slide up on the screen again, with your
Definitely.
contact and all of those links?
Oops. Let me go back to it in my browser correctly. Sorry about that. All right, that should help. There we go. That is the best way to reach us. Or me. There are 3 of us now, so it's not just me anymore. And the request for screenings data is this link here as well. So let me grab that link. Oops.
That's nice. I did love your memes.
I have to do them. And it was Halloween, right? You've got to use that when you're talking about tea. When it came up.
So tell us who your other 2 coworkers are now so that we can get familiar with the names.
Malaya Rivers is our outreach coordinator. So she's the one who's going to be at a lot of the tabling events and events outside, and coordinating volunteers for those as well. We're hoping to do a lot more of that in the next year. And then Sam Ownby has joined us. She actually works at the Psychological Association as well. She's doing our social media. So you may get Sam or me responding to social media things, which is great. She's fantastic.
Okay, I just want to say thank you, Marcie, for joining us for this presentation. And to everybody that tuned in this morning, thank you for joining us. Like I said earlier, in the coming weeks, if you were present for at least 90% of the content portion of the webinar, you'll receive an email that provides a link to your session evaluation and then your certificate. Like I said, that will happen in the coming weeks. It will not happen within the next couple of days. And be sure to register for every Learning Series session using the same email address. I can't stress that enough.
Super important.